Good afternoon, everybody. We are glad you could join us today for the ECG webcast, Key Steps to Ensure the Business Office Captures Revenue Due from Commercial and Government Payers. I'm Dan Costantino, a manager at ECG, and I'm pleased to be your moderator for today's program. Today's panel discussion by ECG's Ambulatory Surgical Care Services team will focus on the key steps ASCs should take to optimize reimbursement from commercial payers and government contracts. Our conversation will address ways the business office can capture appropriate revenue from payers at a time when a rapidly changing economic environment may pose additional challenges. Additionally, our experts will discuss the importance of understanding payer contracts, payment policies, and reimbursement methodologies to maximize reimbursement through contract compliance and management best practices. And finally, we will examine payer trends that continue to impact ASCs and revenue. Before we begin the formal program, let's go over a few details about the webinar. Today's program will be 60 minutes in length, which will include 45 minutes of presentation and 10 minutes for questions and answers. Everyone should have received a copy of the session handout, but if you are a late registrant, you can download the handout in the handout pane on your screen. Attendees are participating in listen-only mode, but if you have questions, you can type them into the questions pane on your screen at any time, and we will address them at the end of the formal presentation. If we are unable to answer all the questions today, we will follow up with you after the session. And finally, upon exiting today's program, you will be directed to an electronic survey. Your feedback is important to us, so please take a minute to complete the survey. And for each completed survey, ECG will make a $5 donation to Doctors Without Borders. Joining me today is Matt Hilton, a principal at ECG who leads the Managed Care Contracting Division of ECG's Ambulatory Surgery Practice. Matt has over 25 years of experience, including 18 years of managed care contracting on behalf of ASCs, physicians, and ancillary providers. Welcome, Matt.
Thanks, Dan. It's great to be here.
Also joining us is Amy Coletti, an associate principal in the ECG Ambulatory Surgery Practice. Amy has over 25 years of experience representing both payers and providers, including ASCs, physician groups, and hospitals in managed care contract negotiations. Welcome, Amy.
Thanks, Dan. I'm glad to be joining today's discussion.
And finally, Kevin Dowdy is a senior manager in the ambulatory surgery practice. Kevin has spent over 20 years working among the foundational departments of healthcare provider organizations, which is demonstrated through his deep understanding of provider contracting and its impact on the broader enterprise. Welcome, Kevin.
Thanks, Dan. Glad to be here.
So now to our agenda. First, Matt and Amy will cover key facts about reimbursement methodologies. Next, Kevin will cover operationalizing contracts to maximize revenue, and we will conclude the presentation with some questions in the discussion. Moving on to our meeting objectives. During the presentation, you will learn about payer trends that continue to impact ASCs and revenue, and have a better understanding of payer contracts, payment policies, and reimbursement methodologies. At the conclusion of the presentation, you should be better equipped to maximize reimbursement opportunities through contract compliance, and hopefully you'll have identified some best practices that can be used at your ASC. I'll now turn the program over to Kevin for a section of operationalizing contracts to maximize revenue. Excuse
Thanks,
me.
Dan.
I'm turning it over to Matt.
Thank you, Dan. I appreciate that, and welcome everybody. So I'm going to start by laying the groundwork and bring a little history to the conversation. And the focus of this first section is to discuss the changing payer environment, or the evolving payer environment. And as many of you know, the payer environment in the U.S. is constantly evolving. We've seen change for years, and it continues. Payers utilize in the ambulatory surgery space different customized reimbursement methodologies. Unlike the physician space, where it's fairly consistent using an RVS methodology, most of the major payers in the U.S. use a custom methodology or a methodology that is proprietary to their specific systems. And even though they may sound the same or use similar terms, there really are a number of differences between each payer's approach to reimbursement. Multiple payers are utilizing policies that impact site of service and are really designed to direct care away from higher cost settings into lower cost settings like ambulatory surgery centers. So that's great for our industry, but it also is moving cases out of surgery centers and into physician office settings. So we see that shift occurring and continuing to occur. Changing methodologies enable payers to reduce payment without renegotiating a contract. So that's where they may deem a service bundled, or they may deem it unpayable anymore in a facility setting. And those aren't negotiated terms, those are payer policies. And so it's incumbent upon providers to remain mindful and aware of those changes and obviously adjust their approaches when those changes are identified. Payers and employer groups are also working closely to establish payer benefit designs or benefit design systems that eliminate co-insurance or co-pay or minimize that amount that the patient is responsible for if the patient moves into a surgery center. So again, that's great for our industry, but at the same time, it does make it a little bit more complex for collection purposes and incumbent upon the billing department or the surgery scheduling team to understand, is this a benefit design that the patient has an out-of-pocket expense or does not have an out-of-pocket expense? And you might get one United patient has one type and another that has a different type. So it can become a bit difficult to track those things and important to do so effectively. We've seen a diminishing amount of access to reimbursement if patients are out of network. The out-of-network space continues shrinking. I feel like we've been saying that for a dozen years, but it continues. And as the Medicare population increases, the need for enhanced reimbursement from commercial payers expands. So Medicare allows a service to be provided in the surgery setting, the ASC setting, that historically was not, and payers don't necessarily have a methodology or a rate for that service. So it's incumbent to ensure that the ASC is contracting and adding those services to its existing agreements. It's always important to understand cost when negotiating rates and terms, and those costs are increasing. I'm sure you've all heard with inflation in the last 12 months, pegged at about 6%. It'll be very important in the next contracting cycle to ensure that you're getting increases to your rates. We talked about payers working with employers on the benefit side. They're also working on the premium side to limit access to high cost providers. So their payers are designing benefit structures that discourage cases in a hospital setting or make a financial disincentive or place a financial disincentive in front of the member. And then lastly, consolidation continues in our industry. We see payers acquiring other payers, and that obviously shrinks the population of potential payers to work with. Overall, all of these variables are affecting business office operations, and high-performing surgery centers have to adjust and update their policies to reflect these changes. So if your business office policy manual was prepared with a Selectric typewriter, it's probably time to pull it off the shelf and ensure that those policies are reflective of what we're seeing in current generation contracting. And lastly, payers have shifted, as we've talked about, cost to the member. So the member is increasingly responsible for a higher potential co-insurance or higher potential deductible, and that places the risk squarely on the ambulatory surgery center's billing team to capture those dollars. So moving on to slide 8, revenue capture starts with understanding your contracts. I think that goes without saying, but it's an important component to touch on. Most centers now will have 4 or 5 major payers: United, Aetna, Cigna, the Blues, and then there are a number of regional payers. You may also have contracts with those commercial insurance companies for Medicare products. So it's really important to understand the terms of those agreements, payment policies, and how they'll impact your expected reimbursement. It's important to stay on top of those payment terms and the contract language that dictates how and when you can ask patients for money and what your responsibilities and risks are with relation to that collection process. There are a number of steps you can take according to a contract to resolve payer disputes or patient disputes, and those terms are really designed to protect, in most cases, the payer and or the patient, and are not necessarily designed to protect the provider. So it's a relevant section of your contract to be mindful of and up to date on. Also, when you determine that a claim may not be paid correctly, obviously it's critical to know how far back in time can you go to recover those losses, and what's the best approach to recover those losses. Is it better to negotiate a settlement or reprocess claims? And most of the payer disputes that we've become involved with tend to have some timeline where the payer really doesn't want to go back and reprocess a claim, and it usually aligns with a calendar year or a benefit year. The worst thing that can happen is the payer realizes they've paid incorrectly and they need to go back, and the patient is potentially has moved on to a different insurance, and so they no longer have the insurance that this claim is paid under. And so situations like that, it's important to understand how far back you can go. And lastly, making sure your charge master is up to date, reflects new services that are coming online, and the be all end all. If you're getting paid 100% of charge, the first thing to do is check the charge master. Is that service being charged adequately? Advancing then to slide 9, let's look at some of the methodologies. Most of these should be familiar to you. Medicare obviously is on the OPPS and has been for some time. The commercial payers use a variety then of additional methodologies. We are starting to see an uptick in the number of payers who are utilizing a percent of current year Medicare, and believe that will continue. But there are other payers who still use either Medicare groupers or some type of proprietary fee schedule. That could be a fixed dollar per code. That could be some blend of groupers and fixed dollars per code. Many payers, although not all, are still willing to consider carve-outs. Usually that's in a situation where a code is just clearly out of place in terms of a grouping assignment, or clearly out of touch with the regard to cost and its existing assignment either by Medicare or that payer. I've seen contracts where a payer will allow 5 carve-outs, and the same payer in a different market will allow 100. So I can't really state that there's a logic or rhyme or reason to the number or the types of services, but it's always important to ask, and being able to explain why is also going to be very important. Then lastly, multiple procedures. Medicare, as you know, is 150/50. Most of the commercial payers fall within that space, although a lot of them do like to discount a third procedure lower than 50%, and others may not cover multiples beyond a certain number of codes. So be mindful of those as well. And then probably the most critical piece when we're thinking about cost in the surgical setting and the impact in the collection space is moving ahead to slide 10, the impact of implants. And for payers, implants are defined as anything that is left in the body after a procedure. And the costs are frequently paid within the procedure reimbursement itself. In other words, paid as part of that procedure. But we do see costs associated with implants that can be reimbursed at a percent of invoice cost. And there are a number of commercial contracts in the markets that have implants paid separately but managed by a third party. And you might know that as an IPG type of an organization that's managing those implants. Really the most critical thing when we think about revenue capture and business office operations and these implants is how they can change the dynamics of a case and the cost of a case. And as Amy and Kevin will touch on here shortly, providing estimates and providing information to a prospective patient on those implants can be challenging. You don't always know how many you'll use. You don't always know whether it will be an allograft or an autograft, or what kind of tissue, those types of things. So this is where the ASC has to get into the business of providing best estimates or best forecasting in terms of what the number and cost of the implant will be, and be able to understand how each payer will reimburse for those implants. Moving to slide 11, we touched on this a little bit earlier, understanding the payment terms of a contract. Payment methodology and rates will vary from payer to payer. It's important for your team to understand what to do when a payer doesn't provide clarity on reimbursement or payment provisions, and bill consistently for all services provided, including those implants. Understand the payers provide a manual. I know those are often voluminous and difficult to get a hold of, and often update without a whole lot of notice. So, best operating facilities are well positioned to understand those manuals, and unfortunately, even the best can't always stay on top of some of the bundling logic that payers will introduce. That last bullet talks about the possibility of payers reordering codes based on contract language. And should you bill the highest allowed code? Should you bill the first code in the procedure? And I've seen differences with respect to the answer to that question based on individual payers. So that's an important question to ensure you understand. And then in terms of challenges, payers provide a fee schedule sample in the contracting phase. You don't always provide a complete fee schedule. It's important to get complete fee schedules, and you're entitled to that information. So please ensure that it's part of the request that you make in a contracting process. And multiple procedure log not being clearly defined is another piece that we see from time to time, where organizations aren't collecting what they should, or not getting paid what's appropriate. We see examples where services are quote unquote missing from the grouper assignments, and how are those handled? Are they at a percent of charge? Are they at a flat rate? And then contracts where the CMS year is not defined. The contract simply says we're going to pay you at a percent of Medicare, but doesn't say what year, doesn't say if the Medicare rate is gypsy adjusted, and variables like that can really change the final output. And then again, our implants paid according to some type of payer policy, either at a percent, or is it bundled, or in certain instances, is an implant paid separately for one service or procedure, but bundled in a different procedure. So those are all elements and challenges that we've come across that we wanted to explain and share with the audience today. I'm now going to turn the presentation over to Amy.
Thank you, Matt. I know you talked a fair amount about some of the implant information and contract methodology, and I have a few slides here where I'm going to get into some more details to help the group know and what to look for in the contract, with some of the differences here with implant reimbursement. It can really vary drastically by each payer, and so the details are really important so that you can ensure for your ASC that you're getting paid correctly. So there's a lot of information on this slide, and I'm going to kind of talk about some of the components and details in each of the sections. So over on the left, I'll kind of start at the top and then work down and over. You may see different provisions. So payment equal to invoice cost, or invoice cost plus a certain percent, like 5 or 10%. Again, the details are important, especially as you move down to if the payment methodology is related to payment equal to a percent of billed charge equivalent to cost, or equivalent to cost plus a certain percent, it means you really need to calculate how to bill for that with your markup. You may need to adjust your markup so that you're billing correctly for that payer. And of course, through all of this, I want to make sure that even if you don't have to bill the invoice, which a lot of payers, of course, with these two provisions that I was just mentioning, it's ideal that you wouldn't have to submit the invoice because that's a lot of documentation for the ASC as well as the payer to deal with. But the payer could come back and audit, and most contracts do include language that they may audit to ensure that you're not billing more than you should per the contract. So a couple other types of methodology you may see is there may be carve-outs for implants associated with specific CPT codes at a percent of billed charge up to a cap or a certain cost. And then you may see thresholds, thresholds either on the upper end or lower end. So there may be payers that don't want to pay for really expensive implants. So there may be implants paid up to $1,000 or $5,000 or some other amount. So if you're doing some complex cases that have high cost implants, of course, be careful in doing those cases. And then there may be other contracts that limit the lower cost items. They don't want to deal with the $200 item or something less than, say, 250 or 500. Those are some amounts that we tend to see. So an example would be, and here's where it's important to understand, is it by the individual implant or the aggregate of the cost of the implants? So a contract, you may see an example, perhaps there's a $500 threshold for the aggregate cost of implants. That means if one item is $400, you would not get paid for that. But if you had two items that were each $300, that $600 total would mean there's payment. So again, the billers should be mindful of what to expect for each of those payers if they do pay for implants separately. Oftentimes, and many of the payers, if they follow a methodology similar to Medicare or other type of case rate, they don't pay for implants separately. Or as Matt mentioned, they may use a third-party vendor such as IPG. So just identify by each payer what to expect so you can monitor and ensure that you're getting paid correctly. So let's move on to slide 13. Let's talk about the importance of payment policies. They are part of the contract and they can change. Matt touched on this a little bit, and what's really critical is that it is an extension of your contract. The rates, the terms, the reimbursement methodology can change if the payer updates their payment methodology or payment policies. So, and it allows the payers to negotiate, basically change the methodology or the rates without negotiation. They can just send a notice and indicate that they're making a change. So be sure to monitor payer websites, notices, newsletters for any updates. And I know that sounds cumbersome, but it might be helpful to have a staff member who's assigned to monitor those types of things, because payers can change fee schedules, grouper methodology, bundling. They may decide something is now considered experimental or medically unnecessary because of some new clinical indication. So it's a good idea to stay on top of that. The payers do make those changes and we deal with it all the time. So let's move on to slide 14. Here are some examples of payment policies that we've seen that present challenges. And I won't read each of these, but they have a common theme. They tend to reference plan fee schedule, payment policy of the plan, usual and customary, or something related to a fee schedule appendix. So anytime that there's a vague reference like that, it's a good idea to talk with your contract manager or provider rep to obtain those fee schedules or payment policies that might be referenced, so that you can ensure you know what to expect to be paid and monitor those payments. And always be aware of that last item there, the Dear Provider letter that comes in the mail. It looks, maybe it looks innocuous. It's just a nice little letter from the health plan. But if you do see a material change, do the analysis as quickly as you can. A lot of times payers have a timeline in the contract that you must dispute something, or at least send them a notice that you think it's a material change within 30 days, 60 days, or 90 days. So again, have someone on your team, a staff member, monitoring those types of notices to bring it to your attention so that you can stay on top of any changes that might affect your reimbursement with the payer. Let's move on to slide 15, please. It's important to understand the payer claim submission requirements. Again, each payer has its own requirements. They don't all follow the same methodology, even within a state. So some states have certain regulations related to either timely filing or appeals, but payers can make some adjustments to that, and they have their own requirements. And if you do miss those timelines, it would result in denials and loss of revenue for your ASC. Ideally, if you're in negotiations, it'd be nice to target 365 days for claims payment or claims submissions, or 180 or at least 120. But keep in mind that a lot of payers have self-insured business. So the national payers, Aetna, Cigna, United, a large portion of their business, and even the Blues plans, more often have a large portion of self-insured business, anywhere from 60 to up to 90% in some cases of their business is self-insured. And that means that those employer groups could move on. They may have a different carrier as they switch plans, or they may go out of business, and then there's no payer to make those payments. That insurance company is just a claims processor for those employer groups. They are not at risk to pay you those claims. So ideally, of course, submit the claims as soon as possible, and understand that within 60 to 90 days for those types of payers is really critical. It's if you're in negotiations, you want to make sure you have the option to resubmit claims and follow up and have longer time periods when possible, but always know that there's risk with that. And then, of course, identify your appeals process and timelines. It will vary for each payer, and when it comes time to deal with claims issues, it's good to have those documented so you can stay on top of that. So moving on to slide 16. So what do you do when your ASC is not paid according to your contract? We see it often. I hear from my ASCs all the time, unfortunately, that they've had some type of claims issues. And of course, the goal is to capture the appropriate revenue from the payers. And there are a couple of different types of claims issues or buckets, I would say. There's the individual claim that has some particular issue that you need to deal with. And then there are bigger issues where, I would always suggest, if you have a new contract, to audit those claims payments, within the month after the contract is effective. Don't wait too long. And if there is an issue, if something wasn't loaded right, ideally, you follow up with the payer sooner rather than later, before too much time passes. If it is just one claim, follow the normal process that I'm sure many of you do, following up with customer service, if necessary, appeal it, but always document the steps, the reference numbers, the phone calls, the reps who are, your staff speak to. Sometimes when it gets to a point where a claim isn't resolved and it becomes a situation where there are multiple claims and we need to submit a spreadsheet, the payer will request a spreadsheet. And if you've already built that documentation, it won't be challenging. But if you have to go back through files, or someone isn't sure who they talk to, it makes it more difficult to resolve with the payer. So keep track of the information. And if it is a global issue, if you see the contract isn't loaded correctly, contact your provider rep or your contract manager, whoever you worked with on the contract. If you realize some type of rate or carve out or an escalator wasn't loaded correctly, so that you can get on top of that as quickly as you can. Of course, there's always a dispute resolution process. Hopefully it never gets to that point, but contracts do have that information, and you can identify that in the contract language if that's needed. And again, what is the timeline for requesting claims adjustment? How far back can you go? Again, it varies by payer, and similar to filing claims, the claims adjustment time period can vary by the fully insured business or self-insured business. I've seen states have requirements for 365 days or 2 years for claims adjustments, but that can vary for self-insured business. They may have a shorter time period that you need to work within. And so who do you contact at the payer level? If it's one claim, like I mentioned, start with customer service, but if you see a global issue, contact your provider representative or your contract manager. And moving on to slide 17, I know Matt touched on this as well. It's important to review and update your charge master. And there are a number of key points that I'd like to just walk through about why and what you should look for. Again, ensure your ASC doesn't have charges that fall below the negotiated rates. It seems simple or straightforward, but we see it often. And if you've worked hard to negotiate your rates, you want to make sure you're maximizing that reimbursement. So compare to your commercial rates. Also compare to Medicare and workers' comp. Medicare makes updates. You want to be sure to charge more than the contract rates or Medicare or workers' comp. They're not going to pay you more than you charge. So as Matt mentioned, if you're seeing payments at 100% of charges, it probably should identify that as an issue in your charge master. If you've had a change in the payment system, take a look at your charge master. It may impact what you should be charging. Compare to HOPD rates. Also what you might have learned in your market related to hospital systems and what your market will bear. Some payers, if there is a component of percent of charge methodology, they may have a limitation on how much you can increase your charge master each year. Perhaps 3% or 5%. So you need to build that into your analysis. And then it's just important that you want to optimize your payer contracts. You've worked hard to provide the services, so keep updating each year. Let's move on to slide 18. And I'll finish up with a checklist for optimizing your contract reimbursement. Understanding your payment terms is critical. If you don't know what you're going to get paid, you may be losing money. Identify what's included in the contract. Are the rates all inclusive? Are implants paid separately? Bill for all services consistently when you can. Of course, Medicare has rules related to implants that you can't bill, but otherwise I would recommend billing to commercial payers. Audit your claims to ensure that the payer is paying correctly. Don't wait too long. And again, the contract value is only realized if the claims are paid correctly and when you collect from the payer and the patient. I'll now turn the program over to Kevin for our section on operationalizing contracts to maximize revenue.
Thanks, Amy. Let's jump into slide 20 and look at the revenue cycle process. So what is the revenue cycle? Let's start with a quick definition. Revenue cycle is defined as all administrative and clinical functions that contribute to the capture, management, and collection of revenue from patient care. The revenue cycle encompasses the full spectrum of activities. It starts with information gathering, such as obtaining patient demographic information, copies of ID cards, and includes scheduling, billing, account and patient collections. I could spend the rest of this presentation just focusing on this one slide, but I want to touch on 3 areas that are highlighted in the box there as far as key areas to focus that can drive best practices and improve collections and patient experience. So the first one is insurance verification. This step is often overlooked, but it is critically important to support upfront patient collections. Even though it can be difficult at times to obtain real-time information as far as deductibles and how much has been met and out-of-pocket max, don't let that stop you. The online systems are always improving, and of course, you always have the tried and true methodology of calling the health plan. That will always remain an option. The second item I want to focus on is financial counseling. Simply put, that's communication. Communication is so critically important, both to educate the patient, but also to set the expectation as far as what the patient's responsibility is going to be. And with that expectation comes the notion of upfront collections. Communicating ahead of time is key there. Don't wait till the day of surgery for the patient interaction to strive for written communication and documentation of the patient responsibility. So the patient has something in hand by which they can, check back on. And the third item there is check-in and arrival. As you expect, patient experience the day of surgery is very important. They have a lot of things on their mind. So communicating in advance, as previously mentioned, regarding financial responsibility, sets that one aspect aside. Not only helps with improved collections, but it'll help the paperwork process of day of surgery go smoothly. Keep in mind that this is the best opportunity, the best opportunity to collect from the patient and or set up a payment plan if needed. Take advantage of this opportunity, having the patient there at the center to discuss the financial aspects. Even though, like I said before, I could spend the entire time going on over different areas like coding or claim submission, addressing denials, do keep in mind that the front end aspects help drive the success in the revenue cycle. So as we move into slide 21, you can start to see how billing is different across different provider types. And focus here obviously is ASCs, so I want to focus there, but I definitely want to use this as a quick opportunity to illustrate the differences across them. I'll just touch on a couple of key areas instead of reading all these items to you. Obviously you have the handouts, so you can review these yourself, but simple things like claim forms. ASCs use two different claim forms, unlike physicians or hospitals. Coding is different. In a physician office, a physician could do all the coding. In a surgery center, you could have a physician do dictation, and then you have transcription, followed by a coder doing coding. Same goes for hospital to a certain extent, but certainly the ASC can be complex. And then the last one item I just want to point out, and this may not be substantially meaningful in the grand scheme of things, but it's something that really kind of brings to light the differences that ASCs have against physicians and hospitals, and that's just the payment posting process. Something as simple as that. Is it, do you line item based on the procedures performed? Do you do it at the account level? Physicians have their approach based on their scope of work. Hospitals have theirs. ASCs, again, there's some nuance and some complexity there that needs to be kept in mind. And when we move into slide 22, there are some common pitfalls that happen in the revenue cycle process. And I don't want to go through all of these per se, but I definitely want to talk through most of them just so that we can kind of get a lay of the land, if you will, an understanding of what some of these pitfalls are. Starting with data quality. What's the adage? Junk in, junk out. Technology is here supposedly to help us. It doesn't necessarily help me because I'm not the most technically savvy. However, it is designed to help us. But the key piece there is you have to have complete and accurate information when started with, especially demographic information, because that is the building block by which all of the revenue cycle process is built upon. Accountability. So it's good to have roles and responsibilities, but thinking in terms of accountability, it's good for the whole revenue cycle team to have accountability. Incomplete policies and procedures, disorganized structure and process flow, all of these issues, these pitfalls, can lead to a disengaged revenue cycle team and underperforming when it comes to the collections and revenue process. The third item to talk about is staff and support. To avoid this pitfall, have the right people in the right places, have the right systems, training, and leadership. I know that sounds easy and it's quite difficult, and so that's going to feed into other areas, which the next one in particular, management and communication. Having the team to be able to have a willingness to speak fluidly avoid some of the pitfalls that can happen. We all can work in our silos sometimes and work on our specific area, and that's where management and communication kind of works broadly to break down those barriers so that we're all on the same page, going in the same direction. And then lastly, process and tools. Inconsistencies in the revenue cycle process, please avoid those, and certainly make sure that the entire staff have the tools they need to do the job. And I think that speaks back to the management pitfalls of trying to lead the team and avoid making some common mistakes that will negatively affect revenue. On slide 23, we'll look a little bit at the shared accountability of the different functions within the revenue cycle. And as I first mentioned in the definition of revenue cycle, it is broad in scope. A lot of times people start to think of just the business office functions, but it's broader than that. And so I'm going to touch on 4 different areas here, just so that you can talk through the idea of accountability and to improve the revenue cycle process. Front-end staff. So areas of responsibility there, obviously we mentioned it before with our insurance verification, the calculation of patient responsibility, as well as the upfront patient collections. This is that time, as mentioned previously, where you can have the face-to-face interaction with the patients, the most opportune time to have that discussion. And so making sure you're set and ready to understand what to collect from the patient is critical. As Matt mentioned, it's not easy. You have cases with implants where there'll be some variability there, but the ability to estimate and forecast that patient responsibility is critical. And make sure you include some metrics there, collection rates, registration errors, things like that can eliminate denials and improve collections for tracking that front end staff. The providers themselves, timely dictation and complete documentation to support coding. I think that's certainly kind of taken for granted at times, as far as the physicians will get their work done. And I know they have the best of intentions, but sometimes they're really busy and they may walk away from the surgery center and forget to do their dictation. So, make sure you work with your providers to recognize, that timely dictation is important. And you can do that from, we use the metric chart lag, but essentially it's the days from dictation to coding to dropping in a claim. So, just track those metrics to make sure you can communicate back to physicians as far as being, integral part of the revenue cycle team. And then the back end staff. So responsibilities there are, to me, the most important one there is working denials. If you get a denial from an insurance company, then you've got to understand why the denial, what's the root cause of the denial, fix the denial, and then everything should from there flow smoothly, to include, payment posting and collections. Obviously this is probably one of the most obvious metrics to track, and that's days in AR. That certainly, I think, brings to light some issues, but may not explain the full story. And again, things like tracking denials will be important to understand that full story as well. And then lastly, management. Everybody has responsibilities on the revenue cycle team, developing KPIs and other metrics to track the staff, communicating the performance and celebrating successes. Those are going to be key areas for management to help staff improve and maintain their high level of performance in revenue cycle. And moving on to slide 24, I mentioned key performance indicators, KPIs. Well, here are just some, and I won't necessarily go into how the math is performed with a lot of these metrics. And some different organizations may do this math slightly different, but these are the ones that ECG uses to help with their clients. And so I'm just going to illustrate a couple of the highlights here. Days in AR, that's obviously a very important goal. We've set the metric of less than 30 days as a kind of a best practice. And we understand that different provider types and different specialty mixes will have different results. Workers' comp, a center that is heavy in workers' comp may not have the same timelines or best practices as a center that's heavy with Medicare, where payment is usually within a few weeks of date of claim submission. So do keep in mind that these are kind of best practices and should probably be adjusted for best suits the needs of your center. Denial rate, again, another metric that provides some idea as how quickly the clean claims are getting to the health plan, whereby the health plan can subsequently submit payment. And you just can't have blind faith that the claims are submitted correctly and payment's on its way. Work the denials, check the denials, make sure that your denials are being managed and maintained to mitigate delays in AR and collections, etc. Net collection rate. This is one that may not be as prevalent that folks use, but I think it's certainly an important one. And the goal here is to make sure your collections are meeting your revenue expectations. Said differently, if you think you're going to get paid $1,000, did you get paid $1,000 for that service that was provided? So track that. Make sure that your expectations from revenue and collections are meet, and that there's not dollars left on the table, so to speak. The one item that was not mentioned on this list that I think is a good one to bring up, but I won't go into a lot of details, and that's bad debt. One could argue it falls under that net collection rate, but different people look at bad debt in different ways. Some look at it as patient responsibility. Some look at it as total dollars not collected that were expected. So again, different people call it different things, different metrics, different percentages. So do keep in mind that there are different ways to look at these, but these are some of what ECG has identified as best practices for KPIs. On slide 25, it's great that you create these metrics. What do you do with them? Well, I think the best thing to do is start with communication. Have meeting cadence with the appropriate meeting attendees or participants to be able to talk through the KPIs and objectives, and celebrate successes, identify trends, identify opportunities. But what illustrated here are just some suggested meetings, some suggested participants, and the frequency by which those meetings should take place. Again, communication, I can't stress it enough. On slide 26, we start to go, okay, great. For the last 6 slides, we've talked about the revenue cycle process, what we have done, what we can do, how do we improve. Now, I think the fundamental question of return on investment starts to come into question, and when it comes to what steps do I take and what's the ultimate payoff, if you will, when it comes to return on investment within the scope and framework of revenue cycle. And as if you look at these from low to medium to high, you can start to see some common themes as one essentially starts to build on the other. On the low side, you start talking a smaller return on investment. This is kind of focuses more on reviewing existing policies and procedures, developing productivity reports, and identifying key performance indicators. So it's starting the first step towards a high-performing surgery center. The medium one in the middle there, as far as a medium ROI, now we're starting to talk about dedicated resources to address denials. I think there's 2 key areas where the revenue cycle builds on itself. Certainly, patient demographic information on the front end leads to calculating patient responsibility, as well as dropping claims when appropriate as appropriate to the respective payers. Again, it's kind of that building block effect. And again, I start thinking of working denials as the same way. If you don't work the denials, your collections are down. It feeds collections, it feeds follow-up, it feeds a lot of different aspects. So again, start working the root causes of the denials. Is that, like I mentioned, and I'm kind of repeating myself here, but was it patient demographic information on the front end? What was it that's kind of that root cause of denials? And certainly review your bad debt and write-off policies so you're not leaving money on the table. And before it was, in the low side was kind of review. Now you're taking more of an active approach and redesigning the process so that you're improving upon lessons learned. And then certainly in the high category, these are without a doubt your high-performing surgery centers. They're looking at being the best of the best and improving and the reporting of their KPIs so that there's more broader line of sight and management into the successes, the activities, the processes, where areas of improvement could exist. And they think more broadly as far as forming a work group of folks that across multiple disciplines and areas of responsibility within the business office and across the surgery center to ultimately move to the elimination of common mistakes. Reviewing all policies and procedures, that's a recurring piece and an ongoing practice. And the key word there is all, not just some of your policies and procedures, but making sure you're thinking holistically across the policy and procedure aspects of the revenue cycle process. And then last, certainly, automate where possible. If there's opportunities for, improvement and automation and functionality within the business office, by all means, take advantage of it. The key word or phrase that I started this slide with is return on investment. Obviously, you can go crazy with respect to automation and costs associated with it. So, make sure you're getting the return on investment that you're looking for, so that, when you sit back and review your revenue cycle, your processes, you're definitely understanding the scope, scale, and the best practices that are contained within. Well, I definitely want to thank everyone for the opportunity to discuss revenue cycle. Now I'll turn it back to Dan so we can address some audience questions.
Thanks, Kevin. And it looks like we have received a couple questions, but before we jump into those, just a quick reminder to our audience to please go ahead and continue to answer your questions in the questions pane, and we'll address as many of them as possible in time we have left. And I'll go ahead and try to direct these to the appropriate panelist, and others can jump in as needed. So the first question we have for Amy. Amy, do you have any recommendations for resolving claims issues?
I do. I would, I think I touched on this a little bit, but I think documentation is really going to be helpful. So if you realize there's a claim issue, start by making sure you have the correct patient information, auth information, and calculate the expected contract rate so that you can contact the payer, start with customer service, ensure that you know the timeline for adjusting claims issues and appeals. And it's really having that documentation ready so that if you need to escalate it, you're armed with the correct information about the claim. Sometimes I work with ASCs, and they have partial information, but not all of the information needed related to the auth or reference numbers or who they spoke to at the payer. And when we try to escalate it, that information is really critical. Thanks, Dan.
Thank you, Amy. And I think this next one would be for you as well. The question is, are there any guidelines to make sure I have the correct contracts loaded?
Yeah, I think there's some components that I would mention, and then I'll, ask my colleagues if they have anything to add as well. But, make sure that you have the correct contract information so that you can load that in your system. If a payer updates a fee schedule or a group or methodology, or if the reimbursement is based on Medicare, be sure you have the correct Medicare year or the correct fee schedule. Groupers, for example, United Healthcare is a good example because they post their grouper methodology on their website. So load the current and correct methodology in your system so that you have the right rates. And then if you need to, then you can contact the payer and confirm if they've loaded it correctly if you're having claims issues. So it's kind of a continuation, I think, of the first discussion. Load your information so that you're comparing and monitoring claims and all the things that Kevin talked about. And also, if you have escalators in your contract, be sure to load that as well if you have a year 2 escalator or new CPT codes when they're added, in January each year. So those are some thoughts I have.
Yeah, this is Matt. Amy, you touched on something I think is really important, which is the ensuring that the correct rates are in, and I generally try to think of that from the standpoint of the center getting paid correctly, so they're not underpaid. But I've even seen some examples where the reverse is true, where a payer has loaded the rates wrong and they're overpaying, and that creates a different set of challenges with respect to the payer coming back for recoupments. And we've seen some examples where these become really meaningful dollars. So it is problematic both ways. Obviously, it's more common to see a payer being or a center being underpaid, but we've seen the overpayment side create problems as well.
Yeah, absolutely, Matt. And I've had even recently a large payer in one market, changed grouper methodology, and it was really helpful. When the center was various centers monitoring their claims payment, realized something big changed, and we had to address it with the payer quickly and identify what happened and what to do about it. So it's important to catch those situations quickly as quickly as you can.
Yeah, I mean, I've even seen situations, I know we both have, where the problem persists, and then you try to go back to the payer and get it resolved. And the answer is, as you touched on earlier in the presentation, well, we can't make it up, but we can change the contract rates going forward. And then it just delays the capture of cash over time, because they're going to apply new rates into the future, and you've been underpaid in the past, and that just again becomes more of a problem.
Exactly. And then you also have the other challenge can be patients are receiving their EOBs related to the incorrect claims, and so maybe you're expecting a larger payment from the payer, and the patient's thinking that they're due a refund. And so that's another reason you want to get on top of this, because then patients get upset if they're not getting their money back that they perceive related to the EOB. So that's kind of a follow-on problem when there are claims issues.
Thank you, Matt. Amy, and we have time. I know we have a few questions left, but we have time for one more. So I'll direct this one to Kevin. And Kevin, as deductibles have increased, how has that changed upfront patient collections?
Dan, it's a good question, and I think the last statement that Amy made actually has certainly an effect on patient collections. So I guess it starts fundamentally with calculating the patient responsibility correctly. But before I jump into the answer, let me pause for a second and say, fundamentally, I think the process that even though deductibles themselves have changed and increased, the patient responsibility has certainly increased. The process is certainly the best practices with respect to the process remain the same. Those are, communication with the patient. Those are, making sure you're accurately estimating the patient responsibility based on the information that you have prior to the date of service. But I think what has changed, and I think where the question is coming from, is the dollar amounts have significantly changed. So what was could have been a minor mistake previously and was only a few dollar delta is now a minor mistake can be hundreds of dollars. And so that certainly has a meaningful impact on the patient and certainly the patient experience. So, what I've seen is surgery center staff getting more creative when it comes to collecting the patient responsibility. You're using all kinds of different things from, developing payment plans, like I mentioned previously, and I keep just referencing this topic, and that's setting the expectation and collecting upfront. But if you can't do that, like I mentioned, payment plans. I've seen surgery centers developing process to hold credit card numbers on file to process credit card payments on a timely cycle. I've seen even outsource solutions to help with that process as well. So I think fundamentally the process is still the same. It's just being creative, and there's a hypervigilance on being right. So just again, a concerted effort to improve the patient experience and improve collections can be one and the same. Thanks, Dan.
This is Matt. I might add to Kevin's thoughts. I mean, most of the surgery in outpatient surgery centers these days remain elective. And I think it's incumbent upon us to remember that and to ensure the patient is aware that, if this is not life-saving or life-threatening or urgent, it's important they understand their financial responsibility. And to Kevin's point, making sure you can properly quote the amount. And also, frankly, I take my dog to the vet, I go to the dentist, everybody's expecting me to pay at the time of service. And I understand that. And I think we as an industry need to become more focused on also setting the expectation. I'm not saying we turn people away if they can't, but we need to set that expectation that there's an increasing amount, and they should be planning to pay at least a portion of it at the time of service.
Well, Thanks, Matt and Kevin. And this concludes today's program. Please note that if you asked a question we were unable to get to, we will follow up with you after this session. We hope you will join us for future webinars and would also like to make you aware of ECG's extensive library of thought leadership, which can be found at our website, www.ecgmc.com. And there you can learn about our upcoming webinars and these relevant and timely topics. I would like to again thank all of you for attending today's presentation. If you have any additional questions or comments, please don't hesitate to contact one of us via the email information provided in the handout. And one final reminder, we would greatly appreciate you taking a moment to complete the electronic survey upon exiting today's program. As we stated earlier, ECG will make a $5 donation to Doctors Without Borders for each survey submitted. And so thank you, everyone, and have a good day.